into it. I know. It's been a busy week. Busy but good. So and I've been working on the
Okay. Give it a couple more minutes. And then Dr. Richardson, would you like to do the roll call for us?
Sure.
I heard from Judge Block, he won't be here. Dawn won't be here. Laura Neeson won't be here. Paige Clark, I got an email saying that she's out of town, I believe, so she might not be here. Morgan Godfin, I believe I talked to and said that they would be here, but I don't see him yet.
Oh, where's...
Hey, Caroline. Did you get a new office?
There I am. Huh?
Did you get a new office?
Oh, no, it just that I always put my pretend I'm in Hawaii background. And I can't find it. It disappeared. So now you got to see my real office.
No, it's very tidy.
Well, that's only because I'm trying to organize it.
That's very soothing music.
It is. I was thinking maybe we should start every meeting out with, you know, some sort of musical introduction.
So that's the team's whole music. So I'm wondering how somebody's on.
Right. Hey, Morgan.
So, Chair, it says on mine that they're guest waiting in the lobby and that they need to be let in. So I don't know if maybe that's why that music came on.
That could be true.
Nobody's waiting in the lobby. It was an actual call. Somebody was calling into this.
Tony Bigland trying to reach.
There you go. Tony's been admitted.
Well, we can hear you now, Tony.
Well, now you can't see me, but I'm working on that.
Okay.
The first thing we're gonna do is draw a picture of you so we all will remember what you look like. Hey, Chair, we should get started.
Anytime.
If we
anytime you're ready.
Okay. Jill Archer. Jill. Brad Anderson.
Here.
Thank you. Caroline Cruz.
Present.
Thank you. Dwight Holton. Dwight,
Present. Present accounted for, Reggie.
thank you. Appreciate it. Kelly, I saw you. We talked. Hello. Good to see you.
Hello. Thank you.
Morgan, I saw you. Laura's going to be absent today. Nate, we talked to. Paige is absent. Pat, you're here. Chair is here. Representative Solomon or anyone from her office?
Hi, Dr. Richardson. This is Nicole. I'm here, and I believe she's going to join as well, just not here quite yet.
Okay, great. Thank you, Nicole. Judge Block is absent, and Steve is also going to be absent today. And Tony Bicklin is in the room.
So to speak.
By a chin's hair, we have a quorum.
Okay. Awesome. And did we get Jill Gray in here?
Yeah, she's here.
Okay, so we're gonna move our agenda around a little bit if that's okay. And Phil Lemon was unable to make it today. And so Jill, if you're ready, we'd like to move you up to the front of the agenda and allow you to give us a review of the end of session bills.
Sure, absolutely. Let me make sure I have my at-home IT support help with me, so hang on for 1 second. Okay. Thank you. First of all, I apologize. I'm battling a cold. I'm going to do my best to project so everybody can hear me and try not to cough over this next agenda item, but I'm hoping everybody can give me a little bit of grace because I'm not feeling my best. But my at-home IT support has arrived. I've got a few slides to go over, so hang tight, everybody, while we pull those up.
Well, I'd just like to say, Jill, thanks for being here despite your cold, and I wish I had in-home IT support.
Can everyone see that? There should be a slide that says, okay, great, thank you. I had mastered Skype, and at some point I'm going to master Microsoft Teams. I promise everybody. Okay. When we last met, which was 2 months ago, Dr. Richardson asked if I would present to everybody about the bills that were introduced this past session that referenced the commission, just so everybody could know possible work that may be coming our way. So the first thing we're going to do is go through these bills. There's only a handful of them, so that everybody knows what happened to them. Did they pass? Did they not pass? And so that we have a much clearer understanding of the work that's coming our way, at least the work that's being directed to us from the legislature. So the very first bill we talked about last time was House Bill 2886. This is OHA's large omnibus behavioral health bill. There's a lot of content in this bill. We're going to go over in a little bit more detail about House Bill 2086 later. For right now, I'll just say there are 2 places in House Bill 2086 where ADPC is mentioned. The first time it's mentioned is in Section 8, which is the workforce section of this bill. And it says OHA, with the advice of stakeholders in ADPC, may establish minimum rates of reimbursement paid by the authority or coordinated care organizations to addiction treatment providers. That section actually goes on to say that the purpose of this is so that people can access without delay the appropriate treatment service that they need. The second place ADPC is mentioned is in section 16, and this is the behavioral health metrics section of this bill. House Bill 2886 requires the Oregon Health Policy Board, which is the oversight committee for OHA, to create a new committee. And this new committee is going to be called the Behavioral Health Committee, and it's going to have primary responsibility for developing the metrics and the performance or the incentives, sorry, that are going to go into contracts with CCOs and other healthcare providers. House Bill 2086 reserves a seat on this new Behavioral Health Committee for ADPC. So this bill mentions us twice. One time having to do with OHA having the ability to establish these minimum reimbursement rates, but with the advice of ADPC. And we have a new job, a new duty to do, which is sitting on this new committee, the Behavioral Health Committee at the Oregon Health Policy Board. All right. Oh, and I'm sorry, I should mention there's a green check mark by House Bill 2086 indicating this bill passed. So this is work that is coming our way. The next bill, excuse me, is Senate Bill 755. Everybody, I think, will remember this is the bill that contains the legislative changes to ballot measure 110. There was an amendment to Senate Bill 755 that added a non-voting seat to the Oversight and Accountability Council for ADPC. That amendment was adopted into this bill, and as you can see by the green check mark, this bill passed. So we now have a seat on the Oversight and Accountability Council. And the third bill, and shout out to John Pugsley for helping me find this budget note that I missed. There is a bill, House Bill 5006, which is this large omnibus budget bill. If people remember from the news, or from hearing in conversations, each legislator had the ability to invest between 2 and 4 million in ARPA funds in their district. This is the bill that lists out all of those ARPA fund investments, but it also contains a huge variety of other investments, one of which is $300,000 general fund dollars to OHA, and there's an accompanying budget note to this $300,000 allocation. The budget note says that OHA is going to use this $300,000 to study the behavioral health structures for services provided through state agencies and whether the structure adequately meets the current needs of the state as identified by ADPC's strategic plan. The budget note goes on to say that OHA is going to analyze several things. Among them is that OHA is going to analyze additional revenue options, including but not limited to taxes related to alcohol. So I'm going to give you a sneak peek and tell you the bill that related to increasing alcohol taxes did not pass, but this budget note did. So there will be some work for us to do in working with OHA on this really large structural analysis that they're going to do. The next bill on our list was House Bill 3111. This bill, yes.
Sorry, can you go back for a second? Do we know who put that budget note in?
I believe it was Representative Sanchez.
It was Representative Donna Sanchez.
Thank you.
Okay. Yeah, you're welcome. All right. And the next bill on our list was House Bill 3111. This bill would have required that OHA contract with at least 4 recovery community organizations to operate 4 recovery centers, each in a different county. The part of the bill that mentioned ADPC was requiring ADPC to adopt criteria for the selection of locations and partners for the recovery community organizations, and then also develop the annual performance goals for those recovery community organizations. This bill, as you can see by the red X, this bill unfortunately did not pass. It made it to Ways and Means, but did not make it out of Ways and Means. And the next bill on our list is House Bill 3245. This was the bill that tried to update some of the statutes for OLCC so that it incorporated e-commerce businesses. I think we're well aware that there are plenty of businesses out there that are involved in the alcohol industry that are either partially or really exclusively doing business on an e-commerce platform, and that current statutes really don't take that in, aren't able to take that into consideration. Among the things that this bill did was create a task force. It has this really long name that you can see there, on the regulation and enforcement of alcohol delivery by third-party e-commerce providers. That was going to discuss in more detail additional changes, modifications that perhaps needed to be made to, again, continue incorporating these e-commerce type businesses into OLCC's statutes. ADPC had a seat reserved for us on this task force, but unfortunately this bill did not pass. And if I remember correctly, it also made it to Ways and Means, but did not make it out of Ways and Means. And I'll just point out one thing on this one. This is something that needs to happen. So we'll keep in contact with our partners at OLCC to work with them on how to move forward, even though this bill did not pass. And our last bill was House Bill 3377. Many of you will remember House Bill 3377 was the companion bill to House Bill 3296, which was the bill that would have increased alcohol taxes. House Bill 3377 was significantly amended, and so in its final version, it created a task force on substance use, and ADPC had a seat on that task force. Unfortunately, this bill also did not make it out of Ways and Means, and it did not pass this session. So of the bills that we discussed, 6 bills, 3 of them passed, 3 of them didn't. I also have one additional bill that I neglected to put on my list, and that is House Bill 2313. House Bill 2313 was the bill that we asked to have introduced, and it would have done 2 things. One of which was to place in statute items from Goal 1 of our strategic plan, such as participating state agencies meeting with us quarterly and ADPC producing a report showing progress on meeting the goals from the strategic plan. The second part of that bill was requesting a $200,000 allocation to do an inventory of substance use services. I think everybody remembers the legislature in March of this year transferred a little over $20 million out of the new ballot measure 110 funds to OHA, and it reserved $200,000 of that $20 million transfer for doing the inventory. So the inventory is happening. And Dr. Richardson and Tori have been working with OHA and OHSU on doing all the pieces that need to be done to get a project up and running. So the inventory is happening. The second part of House Bill 2313, the part that had to do with placing in statute those Goal 1 items, unfortunately did not pass. The bill, because it originally contained a $200,000 allocation, went to Ways and Means, and there were no objections to the bill, but I think there's so many bills in Ways and Means, I think it just got lost in all of the bills in Ways and Means, and it unfortunately did not pass out of Ways and Means. So if I had a slide for 2313, I might have both a green check mark and a red X. A green check mark because the inventory is happening, but unfortunately a red X for placing those Goal 1 items in statute, and we'll have to continue working with our legislative partners, perhaps in a future legislative session, to get those items in statute. All right. That is the sum total of bills referencing ADPC this past session. Before I move on to the next item, let me just pause and see if there are any questions from anybody.
Not a question, but I dropped the full text of the enrolled bills into the chat if anybody wants to read them.
Thank you. That actually is a nice segue, thank you, into my next point, or my next item, which is I have an end of session report that I'm working on, and actually I'm pretty much done with it. I just need Dr. Richardson to review it and give his approval, and I will be sending that out to everybody. part of the end of session report includes a chart that the Public Affairs Subcommittee asked if I could create. Besides the bills that we just discussed, there were plenty of other bills that passed this session that have some impact on our strategic plan. And they asked if I could try and put down on paper how those bills that passed that impact our strategic plan, how they impact and where they impact the strategic plan. So I am going to give you in the next 2 slides some examples of what the chart looks like so that when it comes to you, you know what this is and you know what it's telling you. So we're going to move on to the chart. And here it is. And it is a very basic, simple chart. There is nothing fancy going on here. But in the first column are the bills. And I'm using House Bill 2086 as the example for this slide. But this will list in that first column all the bills that have an impact on the strategic plan. The next 4 columns should look very familiar to everyone. These are the goals from the strategic plan. So the first one is developing a coordinated statewide system. The second one is promoting effective prevention strategies. The third one is increasing rapid access to treatment. And the fourth one is increasing access to recovery supports. For each bill, I tried to show you where the impact is, which goal the impact was. And then I tried to go even a step deeper to tell you for each impact that bill has on our strategic plan, what is the specific strategy or activity that it impacted? And I even tried to give you a reference in the strategic plan. So for this very first one, you'll see that it says 1B3, that is objective 1B3, so that if you wanted to go the strategic plan and actually see the full wording of this strategy activity, you can do that. House Bill 2086 had multiple impacts. There were also bills that really only had 1 or maybe 2 impacts to the strategic plan, but I chose this one, House Bill 2086, because it had a lot of impacts, and we could go over this one relatively quickly so you can see how this works, although hopefully you're getting the idea. All right, House Bill 2086 did multiple things. We're going to talk about just a couple of them so that you can see how this chart works. One of the things House Bill 2086 did is it removed some barriers for OHA to fund recovery housing. Current statute said that OHA could only fund alcohol and drug-free recovery housing. House Bill 2086 removed that abstinence-only requirement. So now OHA can fund multiple types of recovery housing. So what I said was House Bill 2086 had an impact on this specific strategy activity having to do with providing an array of supports, including housing. And I gave you the specific reference in the strategic plan that you can go to if you would like to read the strategy or activity in its entirety. House Bill 2086 also, as we discussed earlier, it creates this new behavioral health committee at the Oregon Health Policy Board that is going to have primary responsibility for coming up with metrics and incentives that are going to be used in contracts. So I said this bill had an impact on this strategy right here about aligning expenditures to goals, objectives, and outcomes. And lastly, House Bill 2086 also requires a survey of medical assistance recipients about their experiences with behavioral health services. So I said over here in goal 3 that this bill had an impact on this and it's the third one down, on this strategy or activity that had to do with surveying consumers about experiences. I think you get the idea here. I'm just trying to tell you where the impact is. This bill had a lot of impacts, and again, other bills had fewer, but all of them had an impact in one way or another on our strategic plan. I'm going to show you one more example. And there were also, as you can imagine, bills that passed that had a negative impact on the strategic plan. This bill, Senate Bill 317, was the Cocktails to Go bill. And one of the concerns about Cocktails to Go is that one of the ways you could use cocktails to go is have cocktail delivered to your house. And there were concerns raised that the people delivering the drinks were not always verifying the age of the person purchasing or receiving the drink. And so there were concerns about this bill increasing access to alcohol for people who are underage. So when there's a negative impact, I put it in red so it clearly stood out that that bill passed, but it has a negative impact. And as you can see here, I said it had a negative impact on that strategy that can be found at 2A3, having to do with decreasing youth access to alcohol. All right, that is it for my part of the agenda. I just wanted to make sure everybody knew what had happened to the bills that we had discussed before, and that you know that there is a chart coming to you, and I should probably get myself off of sharing here. And hopefully we're going back to stop sharing. There we go. And then to let you know that there is a chart coming to you along with the end of session report that fully describes each of the bills, and the chart that kind of helps map out where those bills impacted the strategic plan. Again, let me pause here and see, are there any questions?
Yeah, guys, we have about 8 minutes, and first I'd like to just thank Jill for showing up again sick, and then also for kind of creating that framework for me to be able to see, like, where are we making progress towards our strategic plan, and then also regressing in it, where were regressions made. I didn't even think about that part of it. So does anybody have any, specific questions regarding the end of session bills that happened or this framework that Jill's creating?
I will point out that several, in fact, I think maybe all of the items that had negative impacts to the strategic plan fell in the prevention section. So I heard Mike Marshall the other day talk about we need to do a lot of re-education, perhaps with some of our legislative partners. I would say that's especially true regarding prevention with our legislative partners. So that's a definite to-do on our list of activities in the future.
Yeah, thanks, Jill. So does anybody have any questions, comments? We got about 7 minutes until Nicole Corbin from the Oregon Health Authority will be giving us an update.
I dropped the Senate Bill 317 full text in the chat as well. All the bills that passed have emergency clauses, which I find a little entertaining for 317, but that's okay. So emergency clauses mean they go into effect upon the governor signing them.
Chair, I have a question.
Yeah, go ahead, Dwight.
I'm Jill, great presentation. Really appreciate this.
And Dwight, I think you're cutting in and out, unless it's just me. Okay, maybe. Is there any other questions while Dwight's figuring it out?
Yeah.
Go ahead, Jill.
If Dwight can hear me, Dwight, you can also always email me, and I'm happy to talk through any bill on there.
Yeah, or you can post it in the chat, but you may have called in. I'm not sure. While we're waiting for Dwight to figure out his audio issues, is there anybody else who'd like to ask a question, give a comment? I see Heather from OCBH said, good job. And there seems to be a disconnect on bills that have potentially negative impacts. Nicely tracked.
And for Heather and others, I should also mention when I have the end of session report finalized, we can post it online so everybody can have access to it. And that would, of course, include the chart.
Thank you for that. It'll be very helpful.
Yeah.
Okay, everybody don't bombard Jill too quickly. Okay, well, if there's no other questions or comments, and if Nicole, you're ready to present, we could pass it over to you if that's okay.
Yeah, thanks, Jill. I'm hoping, Heather, I'm really having a hard time with my Teams today. It's going to war with me. So I'm hoping, I sent you my PowerPoint. I'm hoping that you can show it instead of me trying to share my screen.
Yes, I have it up and ready. Let me just
Thank you.
get this going here.
I feel like that's going to give us a way better chance of success. So, hi, everyone. Thanks for inviting me to speak today.
Can you guys all see that?
No.
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 Let's see.
Honestly, I'm relieved that I'm not the only one who can't see it, because really my my Teams and video has been arguing with me today. So, well, so while Heather is getting that to work, I just wanted to let you know, in case you haven't glanced at the agenda, that I'm here to talk about the fairly significant new investments in behavioral health that come out of both the 21-23, it's in the 21-23 biennial budget, and these investments come out of the legislature, but also out of some additional funds for the Substance Abuse Prevention and Treatment Block Grant and for the American Rescue Plan Act. So we've got some money to put towards substance use disorder treatment, prevention, recovery services, and we're excited about that, as well as other behavioral health resources.
Is that seen yet?
Yes.
Okay, great. Thank you.
Yep.
It's looking promising. Yay. All right. Well, then if you want to go to the next slide.
Okay.
So,
Oops.
Okay, that shouldn't be what there we go.
Okay.
Like I said, I was just toying with Heather and I sent her a blank presentation just to see if she was paying attention. Some of this we'll touch on what Jill already talked about legislation, but anyone who has been part of the work that Oregon Health Authority has been doing with the Oversight and Accountability Council for Measure 110, or was part of listening to the conversations in the legislative session, listening to us talk about the Oregon Health Authority's goal to eliminate health disparities within 10 years, knows that we are in the midst of transformative work, right? And this budget reflects transformative work because these are initiatives that are not just to provide services. And I don't want to soft pedal how incredibly important providing services is, but we want to provide services, but to really realize a behavioral health system that best serves all people in Oregon. And specifically, that means serving people who have previously been excluded or been left out. So we're talking about people of color, we're talking about the tribes, we're talking about people in recovery, we're talking about people with lived experience. So this is a really exciting opportunity and a transformative way of thinking. So we're not talking about just where the dollars are going, but the process and how we'll work differently, right? This is really embracing nothing about us without us. So our work now turns to implementation, which is going to mean hiring, rulemaking, procurement, all the stuff that policy wonks get very excited about, but it really is the infrastructure that makes this work. And Heather, if you want to go to the next slide. So as I mentioned, the goals of this transformation are certainly to use the money to provide services, right? We always do that, but it's more than just meeting those deadlines. It's really changing how we do the work to get better outcomes, which I think dovetails hand in hand with the ADPC/Oregon strategic plan, right? That plan is about changing what has existed to really getting different outcomes and eliminating health inequities. So we're talking about aligning support for priorities across the agency so that you don't have Medicaid incentivizing something that behavioral health doesn't want incentivized. You want everything pulling together. Talking about engaging our partners meaningfully. And that is an interesting balance. The way I look at it is to truly engage partners meaningfully takes time. right? It takes time to have conversations with our partners. It takes time to develop relationships. It takes time to listen. And we also know that we really, really want to move fast because people are dying, right? This is about healthcare. So it's the balance between taking time and moving fast in a meaningful way. We want to remove barriers so that people feel welcome and are able to participate in the process. And I don't just mean the process of getting care, but the process of talking about how that care should go and really creating this transformation working in the community. Redistribute power and resources so that we are not only contracting with the people that we have always contracted with, but really engaging our existing partners because they're wonderful and they do important work, and also bringing in more people to the fold, more community-based partners, more culturally specific partners, people who perhaps have been excluded before. And as Jill mentioned, there's legislation that really talks about providing accountability for those outcomes. The legislature has essentially given us quite a lot of money, and they are giving it to us in measured doses because they want to see outcomes and they want to see accountability along the way. So this is this is exciting, but this is a partnership with the legislature, with our partners, with OHA. It's going to be a lot of work. So if you want to go on to the next slide. So this budget includes the legislature's largest ever investment focused on behavioral health. And especially for this group, I want to emphasize that behavioral health does not mean just mental health. I know that sometimes, right, the phrase behavioral health was really created to be a broad term that included addictive disorders, substance use disorders, gambling disorders, as well as mental health disorders. And sometimes, because it's a clunky phrase, it now becomes shorthand for mental health. So I want to be really clear. This is a behavioral health budget. This includes mental health, this includes substance use disorders, and it also really includes doing work for co-occurring disorders because we know there are so many people who experience multiple different challenges that they need assistance with. So big highlights, $130 million to increase residential treatment services and housing for people with behavioral health needs. And again, this includes substance use disorder residential treatment. This is a big deal because this can include startup funds, sticks and bricks, right? We've had situations before where we've had funding for treatment services, which is wonderful. But if I want to create a residential treatment facility in a community that doesn't have one already, I can't do that if I don't have some money to buy property or, to rehab a building or to, buy desks and computers and beds and that sort of thing. So this is money that is for investment, not just services. 121 million for certified community behavioral health centers, which again are a program that has been, I'm not going to say limping along because it's been doing great work, but it has not been clearly funded and staffed previously. So that is, again, a place where co-occurring disorders happen and the CCBHCs are going to be expanded. 50 million for transformation and system alignment within the behavioral health system. That also talks about some of that accountability, investment in knowing the system works better than it does right now, that accountability program to develop common metrics across agencies. I know that I have talked with both Tony and Dr. Richardson previously about the need for good metrics because those are going to help drive the success of the ADPC/Oregon strategic plan. Again, I think most people who have watched the news or paid attention to legislative efforts know that there has been a significant crisis at the Oregon State Hospital to the point that the National Guard was called in to provide additional services and support. So there's money to open new patient units at the state hospital, money for community services for the people that are called aid and assist patients. And those aid and assist patients are often people with substance use disorders as well as mental health disorders. For anyone who doesn't know, just the quick shorthand is aid and assist is when someone is arrested, but rather than going to jail, they are found to be unable to aid and assist in their own defense due to their behavioral health needs, and they wind up at the Oregon State Hospital, which is not always where they need to be. So this is to create community resources to serve them closer to home, hopefully keep them out of jail, but also keep them out of the hospital and really give them what they need. Again, money set aside for Oregon hospital staffing, and the big one that is it's a huge relief to me, but there's 302 million for addiction and recovery services that are called for in ballot measure 110. I think you may recall us having some previous conversations that there was concern that the ballot measure 110 called for services to be paid for with marijuana money, and there was real concern that that would take away marijuana cannabis tax from services that already existed, and that did not happen. We've got a large investment. And I see that Catherine has her hand up.
Yeah, so I actually just presented to the defense bar here about the new aid and assist bill, the amendments to those statutes. And that specifically referenced inpatient behavioral health as part of community restoration. Is that what some of that money is supposed to be going to, is building those? Because I know that this anything like that. So
some of it is inpatient service, and inpatient can mean at the Oregon State Hospital. It can also, there are a couple of other hospitals that can expand wards, but it includes increased capacity, but it also includes community services. So you can see there's a couple of different places for aid and assist. So a couple of different places at the hospital all are over the umbrella of aid and assist, as well as other civilly committed patients who need care at the hospital.
Right, but so in the statutes that amended the aid and assist process, there was specific reference that to earning jail credit when you're at a inpatient facility as part of community restoration. So not in the hospital, but in some other inpatient setting in the community.
Right, such as secure residential facilities. Right.
So is
Sorry,
that?
I think I was not answering your question.
Yeah. So like in community, in the more rural communities where those things don't exist, can this money go towards maybe helping build that to take some of the stress off the hospital?
Yes.
Awesome.
That is my understanding. Now I'm going to say that the aid and assist is my peer program and not mine, so I might be misspeaking, but that is my understanding. All right, so next slide. So residential treatment services and housing, which I just mentioned, includes substance use disorder services, capital, startup, operational cost, really reflecting increasing statewide capacity of licensed residential facilities and housing for people with behavioral health needs. We've got a budget note that specifies a grant planning process and criteria for these funds. But again, this means that there's the opportunity for sticks and bricks, right, to actually create new programs. I think that everyone here who touches the substance use disorder treatment world at all knows that we don't have enough residential treatment facilities throughout the state, right? They're a statewide resource, but they're not really located statewide. And particularly for people who need that level of care, but are parenting children, need a place where they can go with their kids, or have culturally specific needs, or for the LGBT community, that there's just not a lot of specialized programs. So this gives the funding to increase some capacity. This also goes hand in hand with the Medicaid CMS SUD waiver that I think you heard us talk about ad nauseum, because it took years to get it passed. But that waiver allows us to have facilities that are larger than 16 beds for SUD treatment. And that means that there are a lot of providers who perhaps were not interested in increasing capacity before, but now can do so because they're no longer subject to that SUD waiver. So, I mean, they're no longer subject to that limitation, the IMD limitation. They are subject to the waiver. And if you want to go ahead and go to the next slide. I mentioned that CCBHCs are being expanded. Again, this was originally an 8-state Medicaid demonstration, included additional states. This is a model that it's similar to other value-based models, but this is a model that has partnerships with communities, schools, hospitals, reduces recidivism into the criminal justice system and hospital readmissions, and really is very effective for people with co-occurring disorders. So co-occurring physical health and mental health and or substance use disorders, any expansion there, any combination of those. So if you want to go ahead and go to the next slide. I suspect this is the area that the ADPC cares most about, right? But this is a significant investment in addiction recovery services. So this is going to fund the increased services and systems that Measure 110 called for. This is going to, as I said, avoid, it backfills money that came out of other needed behavioral health services, which were all substance use disorder treatment, prevention, recovery services. So there's a significant investment there. Another piece, if you want to go to the next slide, that I think is very important. I've talked with a number of folks who are on this commission about workforce needs, right? We have a workforce crisis in Oregon. And so part of this money is for recruitment and retention within OHA, but also Heather asks of CCBHCs. Oh, and then your comment went away, Heather. So I'm sorry, I'll have to I'll answer that at the end, I guess, if I know the answer. But we are talking about, obviously, we mentioned that the state hospital had a crisis where it was to the point of needing to call in the National Guard for staffing. So there's additional money set aside for staffing there. But there's also money to increase training for diverse behavioral health professionals, licensed and non-licensed. So we're talking about recovery mentors, right? We're talking about peers. We're talking about LPCs and CADCs and licensed mental health providers and QMHPs, right? This is getting more people into the field, but also getting diverse people into the field, right? We really want to have more people with lived experience. We really want to have more people of color. We really want to have more people in our rural programs. So this includes grants for to provide supervised clinical experience, because again, if you've ever worked in a small program or in a rural community, you know that it can be extraordinarily difficult to find, say, specialized supervision or training that you need for your staff in order to do effective work. So this is one of the bills that I believe you mentioned, Jill, House Bill 2949, which is using incentives such as scholarships, stipends, loan repayment. Many times I've heard people talking about the fact that we are competing with, say, Starbucks or McDonald's for our workforce because they have been able to offer some incentives that we can't. So this is a way to really invest in that workforce and to grow the workforce. Next slide. I think that Jill may have actually covered most of this in her wonderful presentation, but this is just a very quick overview of the legislation that passed that is really relevant to the OHA budget. So 755 is the bill that formalized the ballot measure that was 110 and actually put it into statute. 2806, the Behavioral Health Omnibus Bill, that includes the accountability measures that I was speaking about earlier and mirrors the CCO metrics and accountability commission. It's that commission that Jill talked about that the ADPC would be a part of. 2247, that's the crisis system. That is for, I think many people have heard about this before, but 988 is intended to be the behavioral health version of 911, right? A place to call if someone is experiencing a crisis, so that you get someone who responds to that crisis who is experienced in behavioral health. And that includes people who are knowledgeable about how to respond to someone who maybe is intoxicated or maybe is in withdrawal, so that we reduce harmful outcomes that have happened in the past where police officers have engaged with people who are in a behavioral health crisis and have had really tragic outcomes. This is a way to engage with the correct service at the right time, even though it's a crisis.
And hey, Nicole, Tony,
yeah.
here real quick. I just wanted to give you a time check. We got about 12 minutes left and just wanted to have a little bit of time for discussion. Yeah.
All right. I don't have many more slides, so I'll roll on.
Okay, cool.
Okay. And again, the other one was big budget that talks about the different money. So you can move on to the next slide. And this is the piece that I, again, think the ADPC probably cares about a lot. I care about it a lot. This is the additional money that we got in the Substance Abuse Prevention and Treatment Block Grant. And I just want to call out a few areas that are being highlighted. One of them is this is a block grant, and so we've got federal money that now is available to focus on things other than just opioids. So we always focus on alcohol because I think everyone knows alcohol is the drug that causes the most harm. But we're also focusing on methamphetamine and stimulant use because we have seen a dramatic increase in methamphetamine overdoses in Oregon. So we're going to be doing contingency management, and that is an evidence-based program that involves incentives that go to people who are in treatment, and it's really difficult to, whoops, you skipped a slide in there. It's difficult to pay for those incentives otherwise. There's also the block grant always has an investment in prevention, but we are also doing the additional investment from this expanded piece of the block grant into prevention, because I think that we've talked many times before about the fact that there is really not a sufficient prevention engagement, and there are any number of specific prevention initiatives that are happening. We are doing additional recovery supports, right? We have earmarked a goodly chunk of the money to really focus on recovery supports. This is all very big picture now, so if you want to know specifically what recovery supports we're funding, I don't know the answer yet, but if you have ideas and suggestions, I know that no one is shy, and I've had plenty of people reach out to me already. So we're talking about that. And then more workforce development dollars to go hand in hand with the other workforce ideas, but these are specifically for the substance use disorder workforce system. So ways that we can create resources, ways that we can incentivize people to come into the field, ways that we can help programs to get the staffing that they need. And then the next slide is really just the overview of the block grant of these additional dollars, because these are 2-year. The block grant continues on. The block grant will always exist, but this additional infusion of money is a 2-year program, and this sort of breaks out where those dollars are being spent. Next slide. This just talks about our next steps, right? We got a bunch of rulemaking that we have to do. I am certain that some folks on this committee or who are listening as members of the public may want to be involved in some of those rules advisory committees. There is an enormous hiring and outreach effort right now. Our webpage is listed here. So if you know someone who would be good, who you think would be good working at the state in a lot of different positions, right? We've got positions for Measure 110. We've got positions for, or we soon will have positions related to our Medicaid waivers, or to other initiatives that we have going on. All of our mental health initiatives, our crisis programming. There's just managers, every level from support staff to managers. We have a huge number of positions open. So if you know somebody who would be good working at the state, please send them to this website. We'd love to have them join. We'll also be doing procurement and RFPs for lots of legislation, because there's a lot of money that needs to get out there. Work group, mandated task force appointments, technical supports for the block grant planning grant processes. And that is my last slide. So now I'm happy to take questions. I see there were a couple that came up in the chat. I need to navigate back to the chat. But my chat is slow, so if someone wants to just ask me a question while I'm...
Yeah, and Brad, you have your hand up. Go ahead and ask a question. Dr. Anderson, you're more than welcome to ask a question.
Sorry, was on mute. Hi, Nicole. I'm an addiction medicine physician, been in this about 30 years. I think it's just so critical that we have addiction medicine people leading this for the addiction medicine stuff, and have it be designed and not have it be led by mental health folks, because they are two very distinct disciplines. And you mentioned evidence-based, and it's very important we look at the evidence base such that patients prefer to have their addiction treated in primary care settings, and the further they get away physically even from primary care, the less likely they are to get treatment. And so I think that's real important. Also, we need to, I work for Kaiser. We have our own treatment programs, but so few of the commercial carriers do. So I think we really need to get them involved. So much of what we've always talked about has just been state programs and Medicaid, but to alleviate the crush on all the community programs, we really need to involve the commercial population. Most Oregonians have insurance, and the commercial insurers are not pitching in. So I think those are real critical things. So those are some comments, and I don't know how we can assure those things, but as a clinician, I feel very strongly about that. As a family doc, I do as well in primary care, which I'll extend to the ER as well as to hospitalists, is really our biggest customer in terms of helping people suffering from addiction get better.
Yeah, thank you so much, Brad. And then we have Pat Garrett, you raised your hand, and then Dwight had a comment in the chat as well. Pat, you want to go ahead, and then we'll get Dwight's comment.
Thanks, Chair Vicenza. Nicole, nice presentation. Thank you. Pat Garrett with the Washington County Sheriff's Office. I'm wondering if the investments in the Oregon State Hospital will translate to increased capacity generally for patients, and specifically for aid and assist evaluations. As you know, tragic reality is we have people in custody who are, there's a question, right? The court has called about whether they can aid in their own defense, and so they can be ordered to the hospital, and that's just a really there's some delay there that really challenges their constitutional rights. And so counties like ours have a rapid aid and assist program locally, but the hospital does a really good job. I just wondered from a capacity standpoint what we might expect on that front. Thank you.
So thank you. As you say, the aid and assist situation is really difficult, right? It is, it's an issue of people's civil rights. It's an issue of public safety. It's an issue of people getting the treatment that they need. So yes, part of that investment is to increase capacity at the hospital itself and to increase capacity in the community, right? Because ideally, it would be great if we could have people not in jail, but also not in the state hospital, but getting the level of service that they need supported within the community. I will also say that the substance use disorder services, my team, my unit, is working alongside the mental health crisis unit within OHA, because we know, not for everyone, but for plenty of people who wind up on aid and assist, they've got a co-occurring disorder, right? A substance use and intoxication is part of what leads them to a situation where they intersect with law enforcement in the first place. And the staff of the Oregon Hospital do superb mental health treatment, right? And that is their specialty. And there is only a very small amount of folks there who really specialize in co-occurring disorders or substance use disorders. So part of the goal is to include that SUD focus in the aid and assist world, because that's part of how we get people what they need. So yes, an increase in capacity, both in the state hospital and in the community. It's a significant investment. It should absolutely make an improvement. And I also know that this is one of our most, not just Oregon, but one of our most intractable problems that has historically just been really, really challenging. So even with this investment, I 100% believe it's going to get better. I believe people are going to get the care they need, and it's not going to get completely solved quickly, right? This is one of our really tough ones. But yes, increased capacity in both the hospital and in the communities.
Thanks, Nicole.
Yeah, and Nicole, I'm gonna kind of spin off Dwight's question and just ask, is there a way for you and like Jill or us as ADPC and OHA to start linking some of the investments that are coming out to our strategic plan in a way kind of that Jill's, laid out with that format, so we know what progress we're making and where we're not making progress?
I think that's a fantastic idea. So, you and Jill connect with me and we'll start doing that work. The answer, I think, to Dwight's question is OHA put together a summary table. Our budget and communications people are in the process of doing that right now. There's actually, I think, a bunch of this is a lot of money, and so there's a lot of communication that is going out to really talk about exactly where all this stuff is going, exactly the accountability piece, to have some real accessible plain language information that isn't sort of full of legislative jargon, but it hasn't made it out yet. And so I know I talked to our communication folks day before yesterday, so I know that it's coming soon, and that is a part of it. But I think that the suggestion to explicitly add a connection to the ADPC strategic plan is an excellent idea.
Yeah, I agree. I think that chart will be super handy, Nicole, because just it'll help us look and assess impacts. Because frankly, the biggest impact this year is in the money more than in the policy bills that pass, because the money is tremendous. Cassie Bruschi did a kind of remarkable summary of where the $1 billion went for OCBH. So, Holly and your comms folks may want to check in with her and not reinvent the wheel, because I think she's done a great job of it working with your team.
And then we're about at 2:00, and I seen that Heather, you had asked a couple questions, and maybe you and Nicole can follow up afterwards or something, or text back and forth during the rest of this meeting. Do we have Jessica Krantz here? Did I pronounce it?
You
Jessica,
pronounced
your
it
last name
perfectly,
right?
yes.
First time for everything. And are you ready to present?
I am. I will admit that I have never presented via Teams before, so I'm trying to figure out, I think I found the button to share my screen. We shall see here how successful I am.
If you have any problems, Jessica, I can help you. This is Heather, so I have it up.
Oh, thank you, Heather. I appreciate it.
You're welcome.
I think it's opening. Oh, it's in presenter view. Is it showing up as slide view for others or presenter view?
No, we're seeing it just great.
Okay, excellent. Well, I so appreciate the commission having me here today to talk about the National Institute on Alcohol Abuse and Alcoholism's College Alcohol Intervention Matrix, or College AIM. I'll just briefly state that I'm an associate professor at the University of Oregon, and my research focuses on young adult alcohol consumption and preventative interventions to reduce harms associated with that alcohol consumption. But I'm a clinical psychologist by training, and so also have done sort of more treatment-based work out in the community. But today I'm going to talk about sort of the prevention end of things. So I wanted to set the stage before I talk about what College AIM is by just situating this historically. So NIAAA, the organization who is funding and hosting College AIM, was only created, roughly 50 years ago. So in 1970, in response to the public health problem of alcohol misuse. And it wasn't until 16 years after that before the first article was published, which documented kind of the state of alcohol problems on college campuses. And what that study revealed was that most campuses were relying on an assortment of alcohol education strategies like pamphlets and posters, or discussion-based, like coming into classes, largely warning about the possible negative consequences associated with alcohol use. And there was this clear recognition by 1986 that there was a need to address college student drinking, yet really no clear guidelines on how best to do this. So college campuses were making decisions kind of in the dark. And in response to that, NIAAA in the late 1990s drew together a group of different researchers and other stakeholders to form a task force. And this task force released their report in 2002. And in it, it summarized a tier system for evaluating the evidence base for prevention strategies targeting college students and their alcohol use. Tier 1 included programs that showed evidence of effectiveness amongst college students specifically in 2 or more studies and found positive effects. Tier 2 showed evidence of success with other populations, but not specifically amongst college students. Tier 3 showed theoretical or logical promise, but hadn't yet been evaluated or found positive effects on alcohol use. And Tier 4 was reserved for those interventions that showed clear evidence of ineffectiveness. And what I particularly want to note here is at the time of that 2002 report, and I and my colleague Mary Larimer were actually part of that initial task force and contributed to the report summarizing all of the available evidence on college-based alcohol interventions up to that point. And we concluded that really Tier 4 included alcohol education alone. So that's not to say that alcohol education isn't important. It's absolutely essential to skill-based interventions, but even back in 2002, we knew that alcohol education alone didn't work, and that again was predominantly what was happening on college campuses. So the task force report was really meant to hopefully support campuses in making a move away from relying on alcohol education only and to choosing evidence-based strategies. So by 2008, roughly 6 years later, Tobin Nelson and colleagues at the University of Minnesota did a study looking at what was the uptake of the task force report, how many campuses were implementing this, and only 79% of colleges were actually aware of the task force report 6 years later, even though every college and university president had been personally mailed a copy of the report to their office, as well as additional copies prominently distributed and advertised at various places where stakeholders gathered, different conferences. So there was this big push, but still only 79% were aware of the report, and recommendations were less likely to be implemented by smaller institutions with more limited resources. So it was seen as harder to actually do what was being suggested in the tiered system. And also importantly, only a third of the colleges that were surveyed were implementing an evidence-based, environmental-focused strategy. So far more of that 79% who were aware and were doing something based on the task force report we're actually doing something that's environmentally based. And I think that that's an important distinction before I go into College AIM, is there really are these two camps of individual focused and environmental focused prevention for college student drinking. And so we can think of the individual embedded within the drinking environment. The individual focused prevention strategies really are targeted to changing beliefs and or behavior of the individual, or more recent prevention strategies that have included medication like naltrexone in combination with more talk therapy style intervention, are seeking to change the biological response to alcohol, so making it less pleasurable for college students to drink. And these individual focused strategies tend to be targeted as selective, so at-risk groups, or indicated at-risk individuals. Whereas the environmental focused are seeking to change the contextual factors that promote alcohol use and higher risk drinking, and these tend to be universal prevention strategies. And what we know is, of course, a mix of strategies is ideal, but again, only about a third of campuses were actually implementing anything environmentally focused. And what the common thinking is because they felt like, well, that's outside of our control, right? We can't control that at the local level of the campus. So the reason why a mix of strategies is important, and this really sets the stage, I think, well for College AIM, is the prevention paradox. So imagine this triangle represents the population of individuals who drink, with the area of the triangle equal to the percentage of people drinking in a particular way. So you can see more people are drinking in lower risk ways or moderate risk ways than are drinking in higher risk ways. But the majority of the total alcohol related harms are actually experienced by those drinking in lower or moderate risk ways, because there's so many more of those individuals, even though those who drink in higher risk ways are typically experiencing more alcohol related harms individually. So we really need those universal environmental prevention strategies to target the lower risk and moderate risk drinkers, and the more individual focused strategies to target the higher risk drinkers. So this brings us to College AIM. So College AIM was released in the fall of 2015 originally. I was one member of a 3-person team then at the University of Washington, and we focused on the individual focused prevention strategies side of the equation, and we worked with a 3-person team at the University of Minnesota, which included Dr. Tobin Nelson, who I mentioned earlier had done that study of the uptake of the task force report, along with Tracy Toomey and Kathleen Link. And together we worked with NIAAA and 10 expert reviewers, so other people at other campuses, other researchers doing this work, to pull together what was published as the alcohol intervention matrix. This was updated in 2019, and it's meant to be a living resource with routine updates. So we're hoping, it's been about every 3 to 4 years that we get contacted by NIAAA. We're hoping that in a couple years down the road, there might be the next update. As updates are made, there's the potential to add new features and ratings. So certainly stakeholder input is key. We want to hear your thoughts. If there are things that you don't hear me talk about today that you think would be particularly valuable, we would love to hear that. In particular, I can tell you right now, things that I am going to push for to be included in the next version is greater focus on effect sizes of the different preventative strategies, as well as attending more closely to what interventions work best for what groups. There was actually fairly limited information on that, the last version of the College AIM we pulled together, and there's been more research looking at that, and with a particular focus on sexual and gender minority groups, racial and ethnic groups, and attending to different identity factors that might have implications for the effectiveness or efficacy of interventions. So the overarching goal of College AIM is to increase the likelihood that research will inform interventions to address drinking on campuses by providing a framework for schools to compare and select evidence-based intervention strategies. So College AIM lives in a couple different formats. It is in a website format, and you can see the front page depicted here, and that's the web address on your screen. And there's also a print format, which is depicted there off to the left. It's available as a PDF, and you can click on the button underneath the image to download it as a PDF. Or you can click any of the menu items where it says individual strategies, environmental strategies, to look at the different strategies themselves. And I'll show you a screenshot of that.
Oh, cool.
And it's a little hard to see. I had some animation on this slide that I can't quite figure out how to get the animation to run. But you can see that this is the individual level prevention strategies, a snapshot of this from the PDF version. And the different interventions are actually rated on a number of different dimensions. I won't talk about all of them today, but the primary two dimensions that create the matrix are effectiveness and cost. So you can see that the interventions are arranged in rows of effectiveness, so higher effectiveness, moderate effectiveness, lower effectiveness, not effective. So we've continued to comment on what we know the research suggests is not work. And then we have this category at the bottom of too few studies to rate. And what this is studies that we wanted to mention, hey, we know this intervention is out there, but there's really not enough research done on it for us to confidently say it works or it doesn't work. And so hopefully with each iteration, we look to see, is there more evidence on this approach where we can pull it up and actually provide a rating for it. But so those rows of effectiveness and then columns of cost. So from left to right, lower cost, mid-range cost, and higher costs. And I will say that these are relative costs because each program, I mean, some of the commercial programs, actually the price gets individually negotiated by the company who's selling that commercial program with the campus that implements it or the community agency that implements it. So we can't say definitively the range of dollar to dollar what these are, but we can tell you these tend to cost less than these tend to cost more on average overall across campuses. The same type of matrix with the same configuration of rows of effectiveness and columns of cost is available for also the environmental level strategies within the PDF version. And then if you looked at the website version of College AIM, if I had gone back, here, let me go back to this screen. If I had clicked on that individual strategies wording on the menu strip, it would take me to this page. And here people can click on individual strategies. And then again, it's arranged in rows of effectiveness and columns of cost, and look at information for individual strategies and can actually print out that information to compare it side by side. If you were to click on any one of these individual strategies, let's say brief motivational interventions or BMIs, and this is really the prototypical intervention for indicated prevention on college campuses, the brief alcohol screening and intervention for college students, which is a prototypical BMI. It'll tell you a description of the intervention at the top. It'll provide you ratings on all the dimensions that we rated, so effectiveness, cost, barriers, the amount of research, the public health reach, the primary modality, the staffing expertise needed, target population, and duration of effects for the individual strategies. Duration of effects wasn't provided for environmental strategies. It'll also point you to resources around implementation and then all of the references for all of the research, so all of the evidence base that we use to derive those different ratings. Also from that main website, you could click on the worksheet, and this is meant to help colleges with that sort of comparison and selection process. So there's a place to document current strategies being used by a campus, whether it's individual or environmental, what its level of effectiveness is, its cost, its barriers, its reach, as well as other notes. And then a space for potential new strategies that haven't been tried, again, hopefully derived from College AIM with greater effectiveness maybe than what's currently being used, or broader reach, for example, than what's being used. The frequently asked questions on any given website, I would say frequently asked questions is not a part of a website that I go to, but I will say for College AIM, it's one of the secret gems and highly recommend it because it includes basically when we've heard from campuses with specific questions about how do I explain this to my administrator or what do you do about this situation, we've tried to fold those in. And one thing we got asked, and again, we're hoping to expand this for the next iteration of College AIM, is how do you choose strategies to target specific subgroups such as first-year students, student athletes, members of Greek organizations, so fraternities and sororities, or mandated students, meaning students who have violated campus alcohol policy and are required to attend a preventative intervention as a part of fulfilling that sanction. So you can go and peruse the different FAQs, but that particular one I think is one of the more informative parts. I do want to say before I open it up to questions that College AIM is limited in that we only included those approaches that were available, so were published. And so we did look to have a minimum of 2 studies before we listed a program in College AIM. So there may be isolated studies of programs out there where only one person has ever looked at this, and those were too many to incorporate. So we wanted to look at things that had a growing evidence base, and we set the threshold at a minimum of 3 studies for us to rate effectiveness. So if it only had 2 studies, it's still in that too few studies to rate category, but with 3 or more studies, then we did rate the effectiveness. But if there's programs out there being used, which we know that there's many campuses that are using programs that could be effective, but they've been untested or they've only been used once, those aren't in AIM yet. So every time I give one of these talks, someone will definitely ask a question about, oh, what about this program or what about this program? And my advice is always, if you think that it's working really well at your campus, we definitely want to be able to include that AIM, and what that requires is a systematic evaluation and publication of those findings in order to be included in College AIM. And in the case of individual focused approaches, the criteria that we set is that it had to be a controlled study, that is either comparing 2 active interventions or comparing an active intervention against assessment only or against another type of control group, so that we could say, yes, it works as well as this other intervention that we know works, or it works better than nothing at all, or works better than the reactivity you might get from assessment alone. And with that, I will say thank you for your attention. Also want to acknowledge NIAAA because they are the primary funder for alcohol prevention research, certainly for my research and my colleagues' research, and of course our funding and supporting College AIM. And then do want to again acknowledge the other members of the College AIM development team. So Drs. Mary Lammer and Jason Kilmer at the University of Washington, who were on the individual strategies team with me, and Drs. Tracy Toomey, Kathleen Link, and Tobin Nelson at the University of Minnesota, as well as the 10 independent reviewers who contributed to this. And with that, I would love to take your questions. And I actually can't figure out how to stop sharing. So if anyone has an idea, I would love to know how to turn this off.
Yeah, Jill or Nicole want to hop in?
Thank you. Appreciate the help.
Cool. Thank you so much, Jessica. Does anybody have any questions, comments?
Chair, this is Kelly. I have something.
Sure,
so are there recommendations for sort of traditional students versus like in my community, the university tends to have older students. How does that play out on in College AIM?
It's a great question. There's actually not sufficient evidence for any one approach that's been tested, say, amongst students who might be referred in the literature as non-traditional students. So students that are typically above age 25 and younger students. But I think that's important. What I can say is there's been some more recent research, and this was actually not published in time to be in the last version of College AIM, but will certainly be in the next version of College AIM, that has been focused on community colleges, where the overall mean age tends to be a bit higher than at four-year institutions. And brief motivational interventions have been one of those approaches tested amongst community college students that have been more effective.
Thank you.
Mm-hmm.
Yeah, thanks, Kelly. Does anybody else have any questions? And maybe you said this and I missed it. Do you know how many Oregon higher education institutions are implementing this right now?
Yeah, I don't know the exact number of that. The study I mentioned to you by Dr. Nelson was done pre-College AIM and kind of actually was the impetus for NIAAA supporting College AIM. It'd be really interesting to do that study. I know certainly University of Oregon, we are utilizing this as a guide, and other colleagues that I've talked with. I just actually presented to the Oregon State College Coalition, Prevention Coalition. And so I know that the word is getting out there. And it really is meant to be a tool to help synthesize all of that research for campuses to make decisions on their own about what they think is best. So I don't know an exact answer, but I definitely am hopeful that everyone has had a chance to hear about it by now, and that they might find some part of it that is useful for their purposes. In light of what you were talking about before, just when I joined the call, I didn't really focus on the environmental side of things, but the environmental side of things is really policy heavy. So taxation, control over alcohol density, law enforcement. So, enforcement of the minimum legal drinking age. So certainly all of those things are happening, at the state level in varying ways. I think it's more a matter of how much campuses are getting involved with, say, their local law enforcement, how much they partner with them around some of that enforcement. That probably varies. But there's probably a great deal of, or if not all of them, that are implementing at least some of those environmental strategies that are rated in College AIM.
Okay, thank you so much. Is there anybody else on the commission who would like to ask a question, give a comment, maybe tell us a story about their college days? And Dwight's shaking his head.
Just remember the meeting is being recorded.
Tony, this is Jill. I have a question, if I'm allowed to ask a question.
Of course.
Just, I'm not sure if I'm using the correct terminology here, but this is now the second time I've heard you present on College AIM, and I think it's just amazing. And I'm wondering if there's anything in College AIM that would allow a college or university, if they really want to focus on perhaps a subcategory of alcohol interventions. My main one I'm thinking about is how frequently alcohol is also involved in sexual assaults, and if there's anything in College AIM that may help universities. This is a very inarticulate way to say this, but maybe tackle two things at the same time. If that's something that College AIM can help universities do as well.
Mm-hmm. That's a great question, and it's a very commonly asked one when we give these talks. Although it's more often framed as, is there an equivalent to College AIM focused on sexual violence prevention interventions? Is there an equivalent to College AIM focused on cannabis prevention interventions? And there is one coming out actually on concussion prevention amongst young adults, interestingly, but there isn't currently existing ones for other substances or sexual violence. What I can confidently say, based on the available research on the connection between alcohol use and sexual violence, is that anything that campuses do to reduce the rates of what we commonly refer to as binge drinking or heavy episodic drinking, which is consumption typically of 5 or more drinks on a single occasion. Anything they can do to reduce rates of that on their campus is going to serve to reduce associated rates of sexual violence, because those are highly correlated. And I know correlation doesn't equal causation, but we know that these things go hand in hand. And so you definitely are going to be acting in the service of prevention of both if you target reductions in that higher risk pattern of drinking, as well as reducing then risk to the individual who are drinking in that way, and what we refer to as secondary effects. So the ways in which that individual's behavior impacts the campus as a whole and impacts others around them.
Thank you.
Mm-hmm.
And Reggie, do you have any questions?
There's a question in the chat from the public, if you want to take that.
Sure, we have time. So we got a question from Mike Marshall at Oregon Recovers, and he asked, is there an ability for a state to use this research to easily evaluate the state's efforts to reduce underage drinking?
That's a great question. I mean, certainly what you could use it for is to look at the environmental side, to evaluate what policies are we implementing. How does this align with what the evidence suggests would be effective in reducing drinking? But it doesn't, College AIM in and of itself doesn't actually have tools in there for assessment, which sounds like what you would need to do to complete that kind of evaluation. But you should certainly use it as a reference point for what we know should work, and then you could evaluate how well is that working in our state on the assumption that the evidence suggests that it should work.
And so I have a follow-up question to that. Is there a way, maybe the state already does this, to assess kind of the prevalence on campuses? Mm-hmm. Is there like a survey that happens where they report out? And again, if you already went over that and I missed it, I apologize.
No, I didn't touch on that because that's a little bit outside the scope of College AIM, but I'm happy to. So there's a couple different national level surveys that most campuses implement. So the American College Health Association's National College Health Assessment is typically implemented every other year, though some campuses, I believe, implement it every year. And it gives those campuses the ability to compare not only drinking, but other health behaviors and the rates that are present in their campus, and compare that against national levels and other regional like campuses or the state level. And then the Healthy Minds Survey, which primarily focuses on mental health, but also then does have some overlap with substance use behaviors and other things that relate to substance use behaviors. That's, again, another national level survey. I'm unaware at the state level what we might be doing in terms of assessment. I know that because of federal requirements that every campus, to be compliant and actually get those federal aid dollars for financial aid, is going to be doing some form of alcohol prevention. And that typically involves some sort of self-assessment, but those data may be reported in aggregate, aren't connected to individuals. And so it doesn't allow for assessment of like change over time, but you could look from year to year what the prevalence might be. And they're, you know, I know my campus, we talk about that and we use those data, but I'm not sure how much the College Coalition might be utilizing those data across campuses, and how we might be connecting that with state levels, say among non-college attending young adults.
Right, thank you so much. Well, we have 2 more minutes. Does anybody else have any questions? Okay, I have one more question. So if an institution wanted to institute some of these strategies, who would fund that? Who would fund those strategies?
Mm-hmm. It's a great question. It's I would say highly variable. So in my experience working with different campuses, a campus will often take on part of that work, but there may be community coalitions, especially when you start to think about how the effect of alcohol use by college students might have impacts on the surrounding community. right? Different community agencies might take up funding of some of that prevention work. But I would say if we're focused on college students, it's largely the campuses themselves that are footing that bill, and through tuition dollars and other fees. But I think if we think about young adults across the board, not just those in college, then going back to someone who asked an earlier question when talking about treatment, I think it would be important for us to think about how do we expand prevention into primary care, because that's probably a way we're going to reach more young adults. And there's absolutely sufficient evidence of the effectiveness of brief interventions in primary care and other health settings to support that work.
Okay, well, thank you so much for coming today. We really appreciate it. And for all your knowledge, you apparently know everything there is to know about this stuff.
That's not true, but I'm happy to share what I do know.
I was trying to put you on your toes, but I wasn't able to. You were rapidly responding back to all my questions. But really, thank you so much for attending today and all your hard work and what you're doing for our students on different college campuses.
Well, thank you so much. It was my pleasure. I appreciated this opportunity. Thank you.
And so I think that, if I'm correct, Reggie, that's the end of all our presentations. And so it looks like the next thing that would have been on the agenda would be public comment. And then we were going to have a general discussion. And so I'd like to open it up right now for any public comment. And if Nicole's okay or any of our presenters stay on, I feel okay with you guys, the public, asking them direct questions if our presenters were okay with answering and responding. Okay, don't everybody ask at once. Okay. Well, given that on our agenda, it was until 2:50. Maybe we can have our general discussion right now, and then
Tony,
if anybody comes on, go ahead.
Hey, it's Mike Marshall with Oregon Recovery.
You found the unmute button. Okay. Hey, Mike.
Yes. I'm in a Starbucks in Klamath Falls, so I apologize for the muzak in the background. First off, I have to contrast this meeting with a meeting for my first ADPC meeting 4 years ago when they didn't have quorum and it got canceled. And the arc of the work that's been done here, that Nicole's report today, which I came in the middle of and want to really dig into what she had to say, but it's just a sea change. And so my hat's off to Dr. Richardson for really moving this policy body to the place where it is today. And what a couple things. Number one, there was a big announcement that the states are going to get $28 billion in opioid settlement money. I don't know if it was talked about before I got on the call, but where is that money going to in Oregon? If it's coming to Oregon, I think the ADPC should be front and center in engaging in that conversation and not leave it to the Attorney General to make that decision, or necessarily even the legislature, that you guys should be in there with both feet. I'm also conscious of, and I'm just running through a couple of items here to throw into your discussion bucket, that OHSU is doing an evaluation of what exists county by county. The legislature did a budget note that has a full-time staff person looking at taxation, alcohol and beer and wine taxes, and some other tax mechanisms, as well as to look at how does the ADPC strategic plan get fully funded in years to come. And those two things should be reconciled from my perspective. And on top of that, OHA is releasing the final part of their interim report relative to alcohol taxes as a prevention measure and through the inequity lens. And so I think that should be included in your conversations as well. But somebody needs to sort of get OHSU and whoever's doing the budget note evaluation together so that they are hand in glove and not duplicative. And then the last thing is there's all kinds of people that are starting to come out to talk about the future of Oregon. They're running for governor. And I think that as a policy body to be thinking, now that we have all this money coming into the system, what are the next steps? A year from now, 2 years from now, 3 years from now, so that informs the public conversation while people are debating the future of Oregon. You guys can feed into, the ADPC could feed into that, like, this is our plan, but this is what's still lacking. This is what needs to be done, and these are the reasons why. And I just think continually not just updating the plan, but sort of updating the gaps of what exists and having that be part of the public dialogue would be a huge service, and certainly within the mission of the ADPC. So again, hats off to all of you.
Yeah, thanks, Mike. There's some really good points and some things for us to think about. Appreciate you giving us a little bit of perspective. And Heather, I see you have your hand up. Go ahead and hop in.
Hey, everybody. Thanks. I agree with Mike. Gosh, you guys have done so much work, and it's been a privilege to be able to be a little bit of a part of it on the strategic planning committee and all that. I really appreciate it. And it's so exciting to see Jill's report and see initial pieces of the plan showing up across different pieces of legislation. I think that's really exciting. But the one thing I did want to bring up is, I know we've been talking a lot of forward planning, and especially when we're talking about the assessment of services that are available. And one thing that did not come up today, and I think it must come up today for your consideration as you're talking about things, is the number one reason programming is closing today is workforce. We don't have workforce. We literally are losing programs every week. There's rolling closures across the state. Agencies are 20, if they're lucky, they're 20% underfilled, and they're up to 50% underfilled. And this has happened in the last 2 to 3 months. And so I really appreciated Nicole's presentation today. But some of that rescue fund has to come out to the sector, or the job of OHACU is going to be, I'm just going to be blunt, it's going to be very easy in about 6 months for them to calculate what's available in the community. I don't want to be, the harbinger of doom, but it's extremely serious, and I don't know how else to say it. So I just want to, bring that up as we're talking about these systems, amazing systems investments, but we have to be talking about what we're going to be doing like 3 weeks ago to support the service sector and the workforce, and to encourage more people to come into the workforce. It's hard to encourage people to come into a sector that's having a very, very difficult time. And if we're talking about equity, it's probably not responsible to ask people who've been ostracized to come in at the time when the ship is not there to support them. So anyway, that's all.
Heather, could I ask you a question? You seem like you're kind of talking about recruitment, right? On behalf of your members, what do you think would be some good recruitment strategies, that could be used?
Well, it's both. It's recruitment and retention. Vicarious trauma in our sector is always the workforce place hazard, right? And the more you pile on people, the more you expose them to vicarious trauma. And so we're in a very difficult place with that right now. It's always been an industry hazard for our industry and for those caring people who come into the sector. And then also stagnation of wages because of very large issues which can't be tackled in the amount of time that we need to act at this moment. And of course, we will continue to advocate for rate parity, rate equity for our sector, but that's a longer term project. So the things that providers are doing right now, and we are working with leadership at OHA and giving them a lot of input. So some of the things that have come from our members directly are many members over the last 14 months have increased the wages of their workforce to retain them so that we can compete with the rest of the business environment. So those wage increases vary anywhere from 10 to 25%. 20 to 25% increases seem to be having an impact, but not all agencies can do that. And then the other piece is hazard pay, bonus pay, sign-on for recruitment, sign-on pay, Many of the members already pay for licensure and CEUs and things like that. That's already in their budget. Some do not, but a lot of them do. That's another thing that people can do that could be funded. We actually provided, and I can send that to Jill, a list of recommendations, which were financial, like if there wasn't a bank account that people could, that agencies could access to fund all of these different concepts, and OHA would need to decide which concepts could be part of that flexible application process. But I think the big ones are those kinds of one-time appreciation, hazard, incentive, whatever you want to call them, sign on, and then also competitive wage, especially as the rest of the economy starts to really be successful and offer really competitive wages that we just can't compete with. It's just not possible for workforce. So I think those are the monetary pieces. The policy pieces really around streamlining and removing administrative burden, which can happen at the CCO level, the state level, and the other local payer level, to help drive more consistency for the workforce. Because if you have 15 clients and each of them has a different CCO, you have to learn how to fill out a different form for each CCO. That's a lot of stress on a worker in today's world, with all the stress that we're all dealing with at home and at the workplace and everything on top of it. So more consistency, removing administrative burden, some of it maybe to look at for long term, and some of it probably just for emergency purposes, you know, but really working with our OHA partners to take a look at that also, because that's another stressor on the workforce. Does that help? Is that what you're kind of looking at? So I'm happy to send some documents that myself and a small group of people are working with the Oregon Health Authority, and the governor's staff has been kind enough to attend also, and we'll see where it lands, but I can send those materials over.
No, yeah, sure, that's great. And I just want to say thank you for making time for us in the meeting.
Yeah, no, I appreciate it. And I also just got off, before I came here, I was meeting with Wyden's office to do the same thing. So it's critical. So I appreciate your time. Thank you.
Yeah, thanks, Heather. Is there anybody else who, from the public who'd like to ask our presenters any questions, or from the commission, if anyone has any follow-up questions for Nicole? Okay, well, then we can move on to our general discussion. We're a little ahead of schedule. First thing I just wanted to bring up to discuss again was the strategic planning retreat. And I don't remember exactly where we left the conversation 2 months ago, but I know that we were kind of waiting to plan a date until state employees would be allowed to meet in person. Do we have any update on your guys' availability, Dr. Richardson?
It looks like we'll come back in September.
You'll be able to come back in September? Okay. Now, just kind of real quickly to the commissioners that we have, would sometime in September be feasible with your guys' schedules? Let me ask this another way. I apologize. Is there anybody opposed to meeting in September for a full day retreat?
It'll just depend on the day for me.
So this is Caroline.
Hey, Caroline.
We're still on restriction for travel, so I would love to be there in person, but I think we still need to probably do the same option of having, this is not Zoom, it's the other one, the other program.
Right.
Whatever the secondary Zoom is. So as long as we have both options, and I think I already have, my schedule is really tight, especially being on Measure 110. We meet on Wednesday. So I think as long as we keep the date still on Thursday, I'm okay with it.
Okay.
Hey,
Go
Caroline,
ahead.
is your restriction budgetary or COVID?
it's COVID. We don't believe, we don't agree with the CDC rulings, so we're still on wearing masks in our buildings and taking temperatures, and so we're just not comfortable. I mean, we've been down to almost zero, and we just got 6 new cases just yesterday. So we're going to continue to monitor the cases, and as long as we still have cases, there's going to be restriction of traveling.
I understand. So I just wanted to remind the commissioners, anytime you're traveling on behalf of the commission, that is reimbursable travel. And so if you came in for the retreat, we would reimburse you for your travel expenses.
Tony?
Yeah, go ahead.
A full day would be tough in September given our current staffing, but September 9th would be the best day if I have a day to pick.
Let me ask you this, Reggie. Given kind of the legislative calendar and some of the things we'll want to do to prepare for that, would October be too far into the future?
No, actually, I think October would be better than September because we have ledge days in September. And I suspect we'll be back. Everybody will be back by then. That September date is less sure for me. So October, I think, provides a better option.
Okay, is everybody cool with moving to October? Okay, so I think what we'll do is we'll send out a doodle poll or something of the equivalent for some different times in October, and try to get everybody included in that. And then we'll, follow up with subsequent dietary restrictions and, penthouse suite availabilities. And no, I'm just kidding, and stuff like that. But, where we're going to stay and everything.
Tony, Heather Jeffers just put in the chat that the OCPH conference is the 20th to the 22nd. Heather, where is that going to be at?
Sun River. So if you were interested in coordinating, it's a terrible location.
Well, that's
no, I've been there before. Yeah.
Yeah, it's beautiful. So, but that is our annual leadership conference, just so you know.
Okay, and you'll have the whole place booked out and some conference rooms and stuff.
We do. We have. So if you wanted to coordinate something, let me know. And I don't know. We could see if something's doable or not. If that's because I think that's your week, isn't it? Yeah.
I think so. I don't have a calendar in front of me, but I think so. Yeah. And then, okay, so we've got a recovery community summit, October 22nd to the 24th in Portland. And we had talked about maybe doing the retreat in the Eugene area for our down south folks. So we've got a lot of logistics to work out. Maybe we'll be able to give you some updates in our August meeting.
Yeah. Okay. And does anybody have any suggestions for, items we should discuss during our strategic planning retreat?
Hey, Commissioner Gavin here.
Yeah, go ahead, Morgan.
Yeah, something I just wanted to bring up more broadly, because I also sit on the Oversight and Accountability Council, and they're really emphasizing harm reduction. Like the OAC will certainly be funding, they did in the previous grant cycle and will again. And just as we move toward a more coordinated and collaborative state plan, I just don't want us to diverge from this huge influx of money that's going towards services. And so just seeing where harm reduction is going to fit in with the ADPC and how we move forward, I think that would be really important.
Yeah, no, that's a great suggestion. Totally understand and support that. And maybe that is one of the things that we do at our strategic planning session is kind of look at how we can coordinate efforts and collaborate and communicate with different entities and different things that are happening and emerging. Anybody else?
So, Tony, we have to remember that if we are going to make policy decisions or practices or make, those kinds of things, that has to be public. So we have to be careful around that. We'd have to have a public meeting, open up an agenda and all of that.
Okay.
All the things that we could do around team building, relationship building, the work of improving the way we relate to one another, and those softer kinds of skills related to our work together are all things we can do in a retreat fashion, but the business of the commission can't be done in a retreat unless it's public.
Okay, thanks for the reminder.
Just to keep that in our minds as we think about how to do this.
Okay, so if anybody has any good team building activities, make sure you bring them with us. And then any suggestions you guys provide, Reggie can review them for, compliance to laws and stuff like that. And then we can move forward with the retreat in the right way. Okay.
Well,
go ahead.
All right. Yeah, I guess for the retreat, I'm going to take a risk here. I would like to bring up the issue about, the makeup of the ADPC again. I will say honestly, I felt like when I brought this up last time, I was not given the benefit of assuming best intent and was met with very hostile reaction. And I want to discuss that again. So, taking a risk by saying that, but I want to bring that up again, and I hope we can have a civil discussion about that.
Okay, well, thanks for bringing that up and expressing, your concerns. And I know personally that you have a good heart and your intent's in the right place.
Thanks, Tony.
Yeah.
Does anybody? Go ahead.
I would just love to hear what makes everybody tick. Like what brought you into this field, and not on Zoom. My information retention is so bad on these virtual things, but just like human connection, like what are your motivations? What makes you tick as a person? What's your background? I want you to tell that to me sitting in the same room. And I think that would be so powerful for us to come together, because it's so easy to assume bad intentions or bad faith when you don't know where people are coming from. So just really building up that mutual understanding of our positions.
No, totally understand. I agree with that. Who are you people, that I'm on this commission with, and all these other people I'm in these committees on, you know what I mean? So totally, we'll definitely build that in. So, if everyone's cool with it, we can move on, and I have another kind of topic to discuss, if that's okay. So I just wanted to get, general comments, concerns, suggestions based on, everything that's happened in the last year, and correct me if I'm wrong, you guys, but it looks like we have an increased prevalence of substance use, and co-occurring disorders because of COVID. We've increased access to, alcohol and drugs. We've increased a lot of funding. It appears to a lot of that is going to go to treatment services and then some recovery support. We have a workforce shortage and a problem. And then we have a lot of different efforts going on. And so I'm just wondering, like, all those moving pieces, and we're starting to actualize our plan, you know, and today Jill putting it on paper really was meaningful for me to start to see how things are adding up. Just giving all of those circumstances over the last year and where we're at, do you guys have any concerns, recommendations of what we should be doing, comments about the direction we're going, requests of me and Dr. Richardson, things we could be doing, just anything, given all of the stuff that's happened over the last year? You know, and I would invite the public to comment on what they think the commission could do given the circumstances.
Tony, I continue to think that I continue to hunger for a really thorough understanding of where the money is going and how it ties up to the comprehensive plan. I think we've heard pieces of that at different times, but we've never really. I mean, I don't have a good grasp of where it is, and I don't think it's because I'm not paying attention. I think it's because it's in lots of different places, and no one's kind of brought it together to hold it up to the mirror of the comprehensive plan.
No, that's a really good point. Where's all the money going? Because there's a lot of it. Okay.
We've tried to crack that nut, and frankly, we've been unsuccessful in getting a comprehensive source to sort of answer that question for us, including DAS. So I'm personally at a loss of where to go to try to answer those questions, because I got really nowhere the last time we tried to do it. We had seen a presentation had been made to the legislature that we thought would be a great item for us, but then the person chose not to provide that information and said that the executive branch should find its own way. So I'm happy to take any suggestions anybody has about who and where we pull that together. To date, I've just not been successful in finding anybody who can help us answer those questions.
Yeah, I know the commission has been looking for it for years, Reggie, and it goes back to Mary Ellen's day.
Say again, Dwight.
I know it goes back years, and maybe what it means is a letter from us to the governor's office asking their help, or maybe it's to DAS and OLCC and of course OHA. I mean, OHA knows where most of it is, but we've just never been able to kind of get a comprehensive answer on what is the dollar amount that is spent on SUD and prevention and all the things that are in our bucket, and where is it? And it's, I get that it's complicated, but until we get that, we don't know where the levers are that we need to pull and push.
Agreed. Thanks, Dwight. Yeah, we'll look for ways that we might be, effective in figuring that out. And Dr. Richardson, do you have your hand up? No, it just popped up by your head.
No, Jonathan from OHA has his hand up.
Oh, go ahead, Jonathan.
Oh, hi. I'm actually with Representative Sanchez's office. And there's folks.
Oh,
hi, Dr. Richardson.
I know you. I just couldn't remember who you represent. Sorry.
Yeah, I'm with OHA all the time and all kinds of meetings. So I feel like I work for them sometimes.
Don't we all?
You're honorary, Jonathan, for sure.
Yes, thank you. I appreciate that. Anyway, just pigtailing off of what Dwight said and so many folks that we've worked with this session on this call. The irony, I think, of this session was all these dollars for behavioral health. But I think with some of that data that Dwight was talking about, kind of shifting the political winds in the legislature towards addiction recovery for alcohol, because it was very strange to see the public commitment to behavioral health, but I'm not sure the connection to alcohol addiction, alcohol in particular, addiction and behavioral health was there this session. So I think the more information we can gather to educate legislators, I think the better.
Cool. Thanks, Jonathan. Anyone else? Everybody else, you know. I have not heard from today. Nate, do you have any suggestions? You still with us?
Yeah, I'm still here, Tony. I'm listening, taking it all in, and really excited about the retreat. I share the same interest that Morgan does in just learning about people on the commission and how we communicate better, what our passions are, why we got interested into this work, and looking forward to unpack some of those relationships and, like you said, what makes people tick.
Okay. How about Caroline Cruz? I know you've been doing this work for a very long time. Is there any suggestions you have given the circumstances that we're in?
I think it just seems, I've been in the field a long time, and it just seems like we're reinventing the wheel, and that we really could learn from the past, and we tend not to do that. And I think Dwight's been in the field quite a long time, like some of the other folks, Tony Biglin, and listening to the campus discussion for the college. We did a program, I believe it was in the 90s, and there was a big, heavy focus on campuses. And I think it was like a 3-year program. For some reason or another, it just didn't stay afloat. And there was a lot of young people who were involved, and there was a lot of big push, for dorms to be able to be alcohol, tobacco, and drug free. And that all kind of disappeared. So for me, it's like we keep reinventing the wheel, we keep reorganizing. And this is the first time, I think, in historical history that all of a sudden this past year, everything is going towards behavioral health. And all of a sudden we have all of these dollars. I'm just kind of like wait and see. I want to make sure that we could have a picture, like a puzzle, to see the total picture and look at all the dollars that are coming in, what it's connected to. So, I know Jill did that beginning in terms of the matrix, but I just want to make sure that we just don't give money out, that it really is going to impact the people who really need it. And so I think the measure 110, for the first time, I've never been on such a diverse council. This is the most diverse council I have ever been on. And a lot of the issues are the same things that has happened for years in terms of Native American people and other population groups have not been heard. And I do know, I think sometimes folks think that Native American population has more of an in, but when you really look at our historical history, everyone's on our land. And our land was taken without us being in agreement. And if we were able to get the type of lawyers maybe that we should have had in those days, then maybe that wouldn't have happened. And so for years we fought for a voice. And so I'm very thankful for the folks who have come out and Measure 10 and really putting things out in the forefront. I think it's caused a whole shift in the way we're thinking, and it's the way we've been doing business, I think, within the Indian community without permission. So I'm not saying we don't follow rules, I'm just saying we bend them. We bend them because we want to serve our people. And sometimes rules are more restrictive and they hurt us more than it helps. So I think I'm just trying to keep an open mind, and I think when I got on the Alcohol and Drug Policy Commission, I think I made it quite clear that if I didn't feel like there was any movement, that I was not going to stay on. So I'm really proud of the people who are on this commission, But I have one request, Dr. Richardson, can we have an up-to-date list and who's really on? Because all my lists I have are not current. So sometimes I'm not really sure who's on and who's not. But I just want to keep an open mind, and I'm glad there's a lot of new monies being directed. But I also want to make sure that those dollars are going. I don't want it to get tied up in so many rules that it's not going to reach the people that we need to give it to or get it in their hands. And so I just want us to be able to, I keep reminding everyone, what, we have plans and we put a lot of effort into these plans, and I don't want these plans to become bookends. So that's just, my story. I want people to understand that we put all this effort in the Alcohol and Drug Commission State Strategic Plan. The tribes have a plan. Measure 110, where we're moving forward and trying to establish connections. So I just want us to keep an open mind.
Thank you so much.
I'll get a current list. We do have several open spots, and names have been submitted to the governor's office for consideration. So we'll get a list out soon. Thank you.
And Dr. Richardson, if the commissioners have potential, members, would they send those individuals to you?
Yeah, sure. That would be great.
Okay, thank you so much, and thanks, Caroline. One thing for me that I wonder about is our lack of data, outcome data and treatment data. Who's receiving treatment services, and what kind of services are they receiving, and what are the outcomes of those services, so that we can understand how good we are doing at helping people, and then using a equity lens on that to understand where we need to increase capacity for different communities. And I've had discussions with the governor's office and Steve Allen around data. I just think it's incredibly important to have data, outcome data, treatment episode data sets, for the services we're delivering, because it's hundreds of millions of dollars, and we're dumping more money into it. And we need to hold ourselves accountable and the state accountable for how they spend those money, in addition to knowing where those monies are spent. So that's one thing I really have made a commitment of my own to push our system towards is reporting out data. With the increase in fentanyl that's coming up and overdoses that I've been seeing, and I've had a lot of people die in the last year, to Morgan's point and all the work that she does around harm reduction, we need to figure out a way to keep people alive and invest in harm reduction strategies with Narcan and stuff like that on the street, needle exchanges, outreach. And then also track prevalence data and overdose data in real time. I see them do it with COVID. I get updates daily on presumptive cases, and deaths. And with the scope of the substance use issue, I feel like we could be doing a better job and have some dashboards and understand what's going on in local communities so we could respond better. And then just the very, very last thing, I just invite you guys to think about what are the next action items you're going to do between now and our next meeting, either, towards our strategic plan, help our executive director in his day-to-day work, or just help our community in general. And you don't have to share that with anybody. I just want to put that intention out there. If anyone wants to share maybe some things they think they could do on behalf of the commission outside the meeting, love to hear it. But if not, we can close early if everybody's agreeable to that.
I have a quick announcement
Sure.
coming out of harm reduction world. And it's
Sure.
critical, pretty doom and gloom actually, so sorry about this. So the entire nation is experiencing a naloxone shortage. The number one producer of injectable IM naloxone was Pfizer. We can speculate where they have diverted production resources to. So those were bought through like a semi-informal network that got a huge bulk purchasing discount. So that has completely gone away. They are on back order and are now having to purchase it at full market price, which is like orders of magnitude greater than what it was. So at a time that the country is experiencing the worst overdose crisis in history, our access to affordable naloxone has been decimated. So harm reduction orgs are figuring out what to do with that. Oregon does a better job than a lot of states. A lot of I do national drug policy research, so I'm looking at just like all different states, and we're in a slightly better shape. We get a little bit more help from the state. A lot of programs across the country have no government funding whatsoever, rely on donations, and are very susceptible to price fluctuations like that. But it is affecting anyone, and like especially urban areas that do high volume naloxone distribution because they just have a lot of people. This is hurting them the most. There's not much that can be done at the state level. There is a lot that the federal government could do because the opioid crisis has been declared a public health emergency, but they're not utilizing any of those expanded public health powers. And so I just wanted to bring that to the attention of the commission. These supply disruptions are predicted to go into at least fall of this year, perhaps longer, especially with Pfizer getting approved the booster dose of the vaccine. And so harm reduction organizations are starting to have to release materials on how to respond to an overdose when there is no naloxone present. So that is the current state of affairs right now.
Yeah, thanks, Morgan. And on a personal level, you can reach out to me if you need help organizing nationally. I have some contacts.
Thank you.
Does anybody else have any announcements, anything that they'd like to say before we close? Okay, I do want to thank the following people for attending. Anyone who's from the public, and Nicole Corbin, and Heather. I know you guys are busy in your day-to-day, and it means a lot for us to come here and participate with us and give us updates. Your knowledge of what's going on is really valuable to the work that we do. Thank you so much. And if it's cool with everybody else, we could adjourn 3 minutes early.
Thanks, everybody.
Great
Thanks,
job.
gentlemen.